This is CPT 2020 Respiratory System. Again, in the front of your manual, there is great diagrams. This is a synopsis of all the different body systems or how the respiratory system flows. Air comes in, or the respiratory system starts in the nose and goes all the way down into the lower lungs. So this section starts with the nose. Like a lot of the other sections that we've gone over, starts at the top of the organ system and then flows down. So the nose is the top. You have your incision, excision, repair. I'm just going to do an overview, and then we're going to go back and do some drilling. I'll do a few sections in the respiratory, and then we'll practice a few. That's kind of how I think it flows the best. So you have a few destruction codes for nose, and then other procedures. Remember, other procedures and introduction is that catch-all. So other procedures for the nose, which would probably be very pertinent to an emergency room coder, would be your nasal hemorrhage control, your nosebleeds. You see that pretty common in the emergency rooms. Then we have our accessory sinuses. This could be ethmoid, maxillary, all of your different sinuses are in here. Like I do with several different sections, I kind of give myself a list of things to think about and information together so that I can plug in and get the best information so that I can get the most accurate code. So when you're coding your accessory sinuses, most of the surgeries are done endoscopically. So underneath this section is probably most of your collective sinus surgery codes. And you can bundle them, you can stack them, what I call stacking. So one of the first things you need to figure out is which sinuses are involved. Is it ethmoid? Is it maxillary? And then, was anything removed? So is there an excision of something, a removal of something, an ectomy? Then, was it a partial or complete removal? The fourth thing, did they perform an antrostomy? And then the fifth, were there any polyps removed? So that's just some kind of collective information. Again, I cannot stress how good the 321 coded book is. This is at the back part of chapter 13. It really has good examples for every section in here. There's no way that I can go over all of it. I just kind of hit the overviews, and we practice some codes. There's no way to practice. Well, frankly, there's no way to practice every single code in the CPT before you sit for your board. There's no way. So we just hit the high, codes that maybe are problematic. I try to hit those. I try to hit codes that maybe have a weird combination or something like that. So turning the page into the endoscopy, you will see a lot of green parentheses. And these mean, and it's vital in here, vital. Remember, I've said CPT, you cannot accurately assign a code without really understanding your parentheses. They're additional text, so they're the sideways triangles, but it's the same thing. They're in parentheses too. So what each of these are telling you is, if you're trying to stack your procedures, don't stack certain codes with other codes. So if you're looking at code 31237, it's telling you do not code 31237 in conjunction with any of these. So once you think you have your codes, how they should be, go back and check all of these parentheses, because that will kind of drive you Probably you've tried to unbundle. We all do it, and that will help you not get caught in that. I do some underlining in here just to kind of keep my flow going. This code is more biopsy driven. This is an ethmoid driven. This is maxillary driven, frontal sinus, sphenoidotomy. So those, I just underline those words so that I can hopefully more rapidly get to the correct code. Let's do the next area is larynx. Let's do just a few practice codes in here. So let's do excision of a polyp from the inside of the nose. Excision of a polyp from the inside of the nose, left side, used a scalpel, and there was single layer closure. So this is excision of a polyp from the inside of the nose. So first I got to find my body part. Now I have to find my action. It was an excision. So here's my excision. So here is an excision of nasal polyp, simple. I don't have any documentation that it was anything other than simple. And then it's also telling me that this would normally be completed in an office setting, which is interesting. Whereas the one below it, an extensive excision of a nasal polyp, would probably be done in a facility. Okay, so 30110-LT, it was on the left side. There's a mirror image of the nostrils of the nose. Okay, so that's our first one. Excision of intranasal lesion via lateral rhinotomy left. So again, we find our body parts. So excision of a intranasal lesion. So we know we're nose. Excision is our action. And this is done intranasal via lateral rhinotomy. So let's see if we can find those words. So here's an excision, intranasal lesion. External approach, which is through the nose, that's external, they didn't have to make a hole. Lateral rhinotomy. So we've been able to match up most of our words there. So this would be our code, 30118-LT on the left side. Okay, let's do a few practice in the accessory sinuses, because those can get a little tricky. So a common one, especially like I've said in the emergency department, let's do endoscopic treatment of a nosebleed. Endoscopic treatment of a nosebleed. So endoscopic, I don't see, so I'm under my nose, but I don't see endoscopic. So that wouldn't be the right approach. So here's my endoscopy. So now I need to find endoscopic treatment of a nosebleed. So here's nasal endoscopy diagnostic. Diagnostic means they didn't do anything surgical, so that can't be it. So I keep going down. One thing you do have to watch with this book, it does have great pictures, but sometimes the pictures impede your flow of seeing what is indented or not. So you really have to be careful. So here is nasal endoscopy surgical. So we're getting to the right place with control of nasal hemorrhage. So there's our code, 31238. We don't have a side, so we wouldn't put an LT or an RT on it. Okay, endoscopic anterior and posterior total ethmoidectomy left with left maxillary antrostomy. So if we go back to this list, I've already hit some of the things. So out of what I said, which sinus? Well, they said ethmoid. So we know that. Was anything removed? Yes, they did an ethmoidectomy total. So it was complete. So another question, did they do an antrostomy? Well, yes, they did. They did a maxillary antrostomy. So now we just need to find the right combination of code. So the ethmoidectomy is the big dog here. So I need to find under endoscopy, find my ethmoid. So 31254 starts me with my surgical ethmoidectomy. This says partial, so that can't be right. So I go down to the next one. 31255 is a total anterior and posterior ethmoidectomy. So that's part of what I need there. So 31255. So I would write that down. So I know I'm on the right track, 31255. And we keep going. So I'm just going to keep that sitting there. Probably by now you figured out that you probably need a piece of paper to jot down some of my scenarios so that you can see it and work it through. It's just not feasible at this point for me to have the textbook here and then constantly moving around. It would just be too much. Okay, so we have our ethmoidectomy. Now we have to do that left maxillary antrostomy. So I'm going to keep going down here. I know that I had maxillary. So here we go. 31256 is with maxillary antrostomy. So here's our second code. Now what I'm going to do before I start thinking left or rights or anything, I want to make sure underneath both of these codes that the parentheses didn't tell me not to code them. So I'm going to go back over to 31255 and look underneath here. So I'm looking for 31256 to see if it tells me I can't do that. And I do not see it here. So I'm going to come over to 31256 and I want to look and see if I can do the 31255. And yes, I can. So yes, I can code these together. Both of these codes would be representative of what was done. Remember at the beginning, anytime you're actually removing something, that's probably going to be what I call the big dog. So I would keep, and that was on the left, I would keep your ethmoidectomy as your first code, then comma, and this is your second code because it was done at the same time through the same hole. This is going to be a multiple procedure, so I'm going to put a 51 modifier, and then it was left 2. So that's how I would write that. Okay. Endoscopy frontal nasal exploration with removal of tissue from the left frontal sinus and diagnostic endoscopy of the left turbinate. So as we were going through here, you may or may not have already underlined, you may want to, but here's our frontal sinuses. So this was ethmoids, this was maxillary, this is our frontal. So now that I'm under the right approach endoscopy, I've found my frontal sinus, I think. Let's read the scenario again. Endoscopic frontal nasal exploration with removal of tissue from the left frontal sinus and diagnostic endoscopy of left turbinate. So here, 31276 is our frontal sinus exploration. And it includes, if they happen to take any tissue out, it would include that as well. We do not have, we do have that they took out some tissue. So that's all bundled in there. Now, what do you do with that diagnostic? You generally do not ever code a diagnostic procedure with a surgical procedure. So since those left turbinates are within this body area, you would not code the diagnostic part of it. That left turbinate exploration would become bundled into this. So this is the only code you would code, 31276-LT. Would be if you didn't quite grasp what I was saying about the left turbinates being in this area, you're going through the same hole. Diagnostic generally gets trumped by surgical. You can Google your sinuses and see where those turbinates are located, that kind of thing, if you want to further get a good understanding. Okay, so let's move further. Now we get to our larynx. So we've done nose, we've done accessory sinuses, now we're in the larynx. And the larynx, you will see, starts with your excision, intubation, because that's technically endotracheal tube. ET tube is your breathing tube when they intubate you and put you on the ventilator. So this is where that would be found because it ends up in your trachea. Anything endoscopic, dealing with the trachea. Repair of the trachea. If you look, a lot of your suffixes are plasty. Plasty means repair. And then we have another body part. So let's look at a few examples in here in the larynx. Emergency department, physician places endotracheal tube for a patient in respiratory distress. So we just talked about that one. 31500 is your intubation emergency procedure. That fits perfect. Okay, complicated tracheotomy, tube change prior to establishment of fistula tract. So complicated tracheotomy, tube change. So this still going to probably fall under that weird stuff like other procedures introduction. And you can see right under, and I specifically did these two just so you would know what's in this area. Your 31502 tracheotomy tube change prior to establishment of the fistula tract. Okay, total laryngectomy with bilateral radical neck dissection. So let's talk about that a minute. So total laryngectomy, so that's going to be in here, total laryngectomy. And then a bilateral radical neck dissection, what are they talking about? That is the lymph nodes in the neck, and they're going to do a radical dissection. Dissection is a removal or cutting into. They end up getting rid of them. Okay, so let's find the total laryngectomy code first, and then I'll tell you where you need to go. So laryngectomy, ectomy meaning excision. Larynx is our body part, excision is our action. So we want a total laryngectomy, and they did a radical neck dissection. So 31365 accounts for the laryngectomy side of that. We need an extra code for that dissection of the lymph. So we've got to go to the lymph section, which will be in the back of your cardiovascular. We haven't gotten there yet, but this is where you have to go. They told us they did a bilateral radical neck. So here is my lymph nodes. Here's a limited lymphadenectomy. Ectomy, meaning removal. Lymphad, meaning lymph tissue. So here's your radical lymphadenectomy. And they did a bilateral radical neck. So looking through here, neck is cervical. So the two that we have to choose from is modified radical or a complete. So you might want to write a note here that a radical, not a modified, but a radical is a complete. So you would also code along with your 31365, you're also going to code 38720-59. Your 59 modifier is signaling that this procedure was separate and identifiable from the other procedure. This is not a procedure necessarily on the larynx. This is a procedure on lymph nodes. And then you're going to add a 50 modifier because it was bilateral. And it tells you right here, underneath this code for bilateral procedure, report 38720 with modifier 50. So that's telling you you've got to add that. So how that would be written would be 31365. That's the reason they showed up, was for that laryngectomy. Then they did also have to remove that lymph tissue. So that would be 38720-59-50. Okay, so that's how you would stack. Remember, I always do my money stuff first. 59 is going to deal with reimbursement. 50 is giving us information that it was both sides. Okay, so I gotta find my place. So that's our larynx. So let's move on to the next area, trachea and bronchi. Trachea and bronchi, again, we have really good pictures that kind of give you a visual of how different procedures are done. I know that glares, I gotta keep my hand under there. So under your body part, we've got incision, we have endoscopy. This is where you're gonna find all of your bronchoscopies. Just like the endoscopic accessory sinus surgeries, you can stack your bronchoscopies. You're going to be able to stack your EGDs. You can stack your intestinal scopes. And I'll keep reinforcing that the whole time. We'll do some examples so I can show you how you can stack them. But I put in here can stack. So here 31622 is your bronchoscopy. Everything under here is indented. Again, watch your pictures. It kind of screws up how your eyes flow. Everything is still indented until, that's it. They're all indented underneath that area. Okay, then we go into some very specific bronchial thermoplasty. This would be very specific documentation that you would have. Introduction section always is a catch-all. Kind of weird stuff is in there. So if you're not finding it under specifically your organ and the action, it may very well be there. And then you have your excisions. So let's do let's look at a couple of examples using the trachea and the bronchi. So emergency department performed a tube thoracostomy for hemothorax, inserting a tube for drainage. So let's say that again. They're in the emergency department. The physician places a tube thoracostomy for hemothorax. So if you watch Grey's Anatomy, Christina or Meredith or somebody is in the room and they have to, quote, place a chest tube. And when you see them do that and they put the tube in, all this blood comes out. That's what this scenario is. So, okay, so we've got to find first our body part. So they are not putting a tube in the trachea. They're putting a tube in the bronchi, in the lung. So, I jumped forward. Well, we'll go on. Let me talk a minute about lungs and we'll stay with this. I'm sorry. I jumped forward. Lungs and pleura, same kind of, so hold on to that scenario. I got ahead of myself. I get excited. I talk about Grey's Anatomy and I get excited. Isn't that silly? It's just a show. Okay, so lungs and pleura, incision area, excision or resection, same thing. Decortication, when you see that in your documentation, that means that the surface layer is removed. Just kind of to help you out there. Here is your tube thoracostomy. So I'm kind of giving you the answer to that scenario. I have beside here chest tube, but this is a tube thoracostomy, includes all of the connections to the drainage system. This would be an open procedure. It tells you that it's open. Here's your thoracostomy. Thoracoscopy. I have to think that because I just tried to do an ostomy in the chest, and I needed to do a scope in the chest. Sometimes if you don't say these words all the time, it gets a little rough, so just bear with me. So here are your different scopes for the chest. Lung transplantation, radiostatic radiation therapy. These are very, very specific, not necessarily common, except in those areas that they're specialized in. Okay, so there was our lung. We did go on our emergency department tube thoracostomy. We did find that code 32551. But I do want to go back and I want to do some of the trachea and the bronchi so that we can stack some of those bronchoscopies. Okay, so scenario, flexible bronchoscopy to remove a piece of food inhaled into the left bronchus. So first we have to find our body part, bronchi. Then we find our action. It was a scope, so we're going to be under the endoscopies. And they've put in a flexible scope to remove food that was inhaled. So here is our bronchoscopies that start. So this is rigid or flexible in here. So we don't have to specifically find the flexible. This includes it. And everything underneath here is indented. So we need to find the code that is bronchoscopy, removal of foreign body, or inhaled food. So let's look. We should be able to find that. I just kind of keep going down and looking. So here, with removal of foreign body. So that inhaled food would be considered foreign body. So 31635-LT, because it was on the left bronchus. Okay, now let's stack another one. We'll get back to the front or the first of the bronchoscopies. So this is a bronchoscopy that includes brushings, biopsy, and removal of foreign body. So let's write this out. So we're going to do a bronch, and there's three things they're doing. They are doing brushings, so that'll have a code. They're doing a biopsy. So we have to see. There may be a code for that, may not. We'll just have to see. And they're doing removal of a foreign body. Okay, so this is what we have to be thinking about for our codes. So I start with my body part, bronchi. I know that glares. I'm sorry. I know that's terrible. Then I get to my actions. So under my scope, I have bronchoscopy. So they did a brushings. Well, right here, 31623 is with brushings, bronchoscopy, and it includes everything to the semicolon, and then brushings. So my brushings code will be 31623. Now my biopsy. It says they took a biopsy as well. So I'm at my bronchoscopy. Now I need to find biopsy. So I just look down here. So this is in the bronchi. So here's bronchial biopsy. So this is the next code, 31625. Now we need removal of that foreign body. And we remember this one from the previous example. So 31635. So how do we stack all this? Do we need left and rights? Do we need modifiers? What do we do? So it isn't necessarily money-wise going to matter one over the other because they're all a bronchoscopy. So I would just leave it in the order it is. You can change it around if you want. Maybe your specific employer has a desire for the stacking of these. So in a nutshell, you have 3 procedures with the same scope in the same hole. They're just doing 3 different things. So you're going to have to put a 51 modifier on 2 of the procedures. If your specific facility or physician or employer wants maybe the foreign body removed at first, then you would put a 51 on the other 2. Doesn't really matter. But you're going to have to, what we need to learn is we have to have the 51 modifier. It's multiple procedures. That's what 51 means. Using the same scope, same body areas, just multiple things done in there. Okay? Good job. Okay, let's see. Did we want to do any more of the lung part? Yep, let's do a few more. Oh, put my... Okay, so in the lungs, let's drill down a little bit more. I kind of cheated and got ahead of myself and did that chest tube. So here's our scenario. Percutaneous. Percutaneous meaning through the skin. Cutaneous is skin. Percutaneous needle biopsy of lung, right side, and fine needle aspiration of lung, right side. So they've done 2 things to that right lung. So let's tackle the first one, percutaneous needle biopsy of lung, right side. So we're under the lungs. We found our body part. Now we have to find our action. So biopsies are excisions. Incision is just cutting in. So we've got an excision because we're taking away. So we're going to have a biopsy. This is of the pleura percutaneous needle, so we probably need to underline that because that biopsy is specific to the pleura, which is the sac or the outside part of the lung. And here, biopsy lung or mediastinum, percutaneous needle. So there's our code, 32405. So let me write that down. Anytime I have, always have paper around. I make so many notes. So 32405 is our biopsy. Now, we got to think back about what we've already learned about the CPT. Where are the fine needle aspirations? This was a percutaneous needle. We need a fine needle aspiration. They're actually the very front, that first page under general. That's where the fine needle biopsies are, fine needle aspirations. So this one was fine needle aspiration of the lung. So we know it's a biopsy. I have no indication that there was any imaging involved. So 10021 is fine needle aspiration biopsy. So that's going to be our second code. Oops. So 10021. And then what are we going to do? We've got 2 procedures, same body part. The second one's going to be your multiple procedure. So comparing between the fine needle aspiration and a percutaneous needle, going through the skin is going to be, it's bigger needle, bigger procedure. So this would be your big dog procedure, and then you would put the 51 on the smaller procedure. Okay, let's do another one. Diagnostic thoracoscopy with lung biopsy and surgical thoracoscopy with segmental lobectomy. So we have 2 things going on. We have a diagnostic and we have a surgical. So what do we kind of know is our rule of thumb? If you have diagnostic with surgical on the same body part, you're probably not going to code the diagnostic. So that's something to think about. So we're in the lung, we're in our body part, so we need to find our action. So we know we have the scope section for the chest. So we go here. Now let's read our scenario again. So they did a diagnostic biopsy, and at the same session, they did a segmental lobectomy. So anytime there's a biopsy done at this time of definitive treatment, you would never code that biopsy. You would never code the diagnostic side to that. So here we're looking strictly for surgical and then a resection of a lobe. So let's just kind of read down through here. This is a diagnostic. This is diagnostic. Now our scopes start to be surgical. So we need to look for segmental lobectomy. This is a pleurodesis. So that's a fixating of desis is fixating. So it's a fixating of the pleura. So I'm just going to kind of still go down here. And I'm just looking for lobectomy. And here we go. 32663, lobectomy, single lobe. So that's our code. Now, do we put a left or a right? Yes, because we have lungs. Although one side has 2 lobes and one side has 3 lobes, we still have, you have to signify whether it's the left side or the right. So for this lobectomy, it's an LT on the left. Okay, so that is your respiratory in a nutshell. Not a super long section. We figured out that it goes from the nose all the way to the bottom of the lungs. Your lung transplantation, very, very specific. This is not a common code that you would be using. So, you know the codes are here. There aren't too many to choose from. So that's just the knowledge that it's there is good enough at this point. If you work for a pulmonologist who routinely gets into some of these really technical procedures, then again, you might want to have your coding procedure handbook or coding desk reference for the coder. That would help you navigate some of those tougher codes. So that's it for respiratory, and I'll see you in the next video.